range of alcohol policy issues, including brief interventions for heavy drinking in primary healthcare. Based at Oxford University, he set up and directed the first national unit for health promotion in primary care, funded by the UK government, the first such institute in the world. In the European office of WHO, he was responsible for the alcohol and tobacco programs, set up the organization's first European Alcohol Action Plan, and became director of the Department of Prevention and Health Promotion. He's a past member of the World Economic Forum Global Agenda Council on Mental Health and Well-being, and senior advisor to WHO and its regional offices. He has brought science to policy across a range of public health issues for several governments, intergovernmental organizations, including European Commission, OECD, and public and private sector think tanks around the world. He has over 180 publications in peer-reviewed journals with contributions to The Lancet, the British Medical Journal, and British Journal of Psychiatry, and is the author of, or editor of 15 books in the addictions field. Peter has contributed substantially to the trials on screening and brief interventions for WHO in the 80s, I suppose, and it's a pleasure to have you here.
Thank you, Maricela, and hello, everyone. So I'm going to just give a short introduction of some of the issues coming out of the Scala project, as well as other work on primary healthcare in reducing alcohol consumption. As Maricela mentioned, the Scala project is a project that's being implemented in Colombia, in Mexico, and in Peru. It's a project that's financed by the Horizon 2020 program of the European Commission. I put up the word brief ahead of the title here because what we're talking about is brief interventions. We're talking about pragmatic ways in which primary healthcare can be involved in helping people reduce their alcohol consumption. So first of all, why do we need to drink less? If you look at 40-year-olds, those who drink more than 5 drinks a day, on average, they lose 4 to 5 years of life compared with people who drink less than 1 drink a day, emphasizing that really people who drink and drink heavily lose or die prematurely because of their alcohol consumption. Alcohol is also a cause of a number of different cancers. And for these cancers, there is no level of consumption that is risk-free. Thus, everyone benefits from drinking less alcohol. The greater the amount of alcohol someone drinks, the more important it becomes that they drink less. And there are some people, and particularly those, for example, with end organ damage from alcohol, for example, to the brain or to the liver, such people should not drink alcohol at all. So why should primary healthcare be involved? In primary healthcare, and I myself have been a physician working in primary healthcare, we see most of our patients over the course of a year. That means we contact a high number of people every year. And simply asking our patients how much alcohol they drink, measuring alcohol consumption, and then advising them to cut down helps patients drink less. And this can be done very quickly. Asking and advising can be done in only a few minutes, and patients by and large and most appreciate this. So what do we need to do? In primary healthcare, over time, we need to measure the alcohol consumption of as many adult patients as possible, and thereafter give appropriate advice to cut down. Our primary goal should be to get up to about 50%. That is, half the number of patients we care for having had their alcohol consumption measured. If we're able to achieve this goal, we will have a very significant impact in reducing the harm done by alcohol at the community level. Training helps us to do it. If providers receive short training, and short training can be delivered in 1 or 2 hours on the direct skills that are needed to ask about alcohol consumption and to give advice, then it becomes much easier for providers to do the work. In Scala, primary healthcare providers who had received such short training measured the alcohol consumption of 10 times as many patients as those providers who had not received training. Thus, it is crucial to provide training to all providers. Local support also helps us to do it. Providers find it much easier to undertake this work if local support is available, and if the providers feel that they're not acting alone to do something about alcohol. And in the Scala project, providers who had received local support, including communication campaigns for the public, appeared to measure the alcohol consumption of nearly twice as many patients as those providers who had not received such support. It's vital in all of this work that we involve key stakeholders from the outset. To make the work easier, sustainable, key stakeholders should be involved in decision-making and looking at all the material that's being used and monitoring the program for the outset. If we do this and get the key stakeholders on board in the program right from the beginning, it will then become much easier to scale up the project, to scale up the work, and to make it sustainable and continuable in the future. Stakeholders come from many different places. They should include health departments at different levels, health departments at the country level, or at the regional level, or at the municipal level. It should include the directors of primary healthcare centers and services who have responsibility for managing the work of such centers. It should include people working in non-governmental organizations to help give comment, to help give noise, advocacy to the work that's been done. And it should include academia and experts to advise on the work and to help with monitoring and evaluation. The vital part of the program, and this is something that we will learn from all the subsequent presentations, is that when doing such work, it's vital to learn and adapt. Implementation is an iterative process. It's not a fixed process. Programs need to learn and adapt as they are implemented. And the views and experiences of the providers who deliver the programs need to be captured and fed into this iterative process, so everyone is involved in trying to improve the program and to make it better. So this is my introduction, and we will subsequently hear some of the practical things that have been done at the country level. Thank you for your attention.
Thank you very much, Peter. And now we're going to have a presentation by Dr. Jürgen Rehm. Dr. Rehm is senior scientist in the Institute for Mental Health Policy Research and in the Campbell Family Mental Health Research Institute at CAMH, the Center for Addictions and Mental Health in Canada. He is professor and was the inaugural chair of addiction policy in the Dalai Lama School of Public Health at the University of Toronto. And he holds professorships in Germany, Spain, and Russia. Dr. Rehm has been a leader in generating and analyzing the scientific data needed to inform clinicians and policymakers of strategies to reduce alcohol, tobacco, and other drug attributable harm. His recent research has increasingly included interactions between socioeconomic status, poverty, and substance use, including analysis of policies and interventions with respect to reducing or increasing inequalities. His work has been awarded with numerous awards and prizes, most importantly, the Jelinek Memorial Award, 2003, the European Addiction Research Award in 2017, and the inaugural Ikero Brun Society Award for Advancement of International Research Collaboration in 2021. Dr. Rehm was the past director of the PAHO WHO Collaborating Center in Canada, is a member of our technical advisory group on alcohol policy, and a very long time collaborator in numerous projects. Welcome. Thank you.
Thanks a lot, Maristella. Good morning, good afternoon, good evening, wherever you are. I have one more of the introductory slides, trying to put it all into context before you see the real meat of the project, what has been and what is being done in the countries. So I will speak about Scala in a global context and a little bit about the economics of all. And I've been asked to speak about it, even though it is a little bit premature. So why now it goes. There are two main reasons for alcohol control policies. One is harm, and Peter has already spoke about it, and the other is costs. The costs are principally quite high. If all cost components were to be considered, all the studies which have been conducted so far on economic costs of alcohol consumption since the year 2010 amount to 1,306 international dollars per adult per year. That means all of us, since we're all adults, pay this sum each year. And if we drink alcohol, the costs per drinker are of course higher because there are abstainers in every country. It would be around $1,900. This is equivalent to 2.6% of the gross domestic project. If you're not really concerned about costs, and if you say, oh, well, we don't pay for that really, we do. But still, if you're not economically inclined, another statistic are 3 million of alcohol attributable deaths and a staggering 131 million of disability adjusted life years. And these numbers are annually. They have been confirmed relatively irrespective of the methodology which had been used to estimate it. And alcohol use was seen as a major risk factor for communicable, I'm speaking of, for example, AIDS, sexual transmitted diseases, non-communicable, like cancer, Peter already spoke about it, heart disease, liver disease, and injury deaths. So those are really compelling reasons to reduce alcohol consumption and to start alcohol control policy. What has been done in alcohol control policy? What are the current suggestions? The current suggestions of WHO are the SAFER, and the SAFER stands for strengthening restrictions in alcohol availability, for drinking driving countermeasures, that is A, for advance those. You always have to be in line with your acronym, to facilitate access to screening, brief intervention and treatment, to enforce bans on alcohol advertisement, and to raise the prices of alcohol via excise taxes and other fiscal policies. So basically, screening and brief interventions, what Peter spoke about in very general terms, is one of those 5 recommended measures. People are now asking, and that is what I've been asked quite a lot, how cost effective are those measures of SAFER? Is it enough that WHO just says these are cost effective measures? In fact, there had been studies on 10 countries on the comparative cost effectiveness of screening and brief interventions with other alcohol policy measures. And what has been done was the free Best Buys, increase of excise taxes on alcohol beverages by 50%, the enforcement of ban on the restrictions on advertisement, promotion, and sponsorship, reduction of physical availability, enforcement of drink driving laws, and the provision of brief psychosocial interventions for persons with hazardous and harmful use of alcohol. When all of those are compared, we looked into the individualized interventions, identified the level of the intervention, identified the time which is necessary, for example, for a brief intervention. We identify the next steps referring to outpatient or to a hospital. We looked at the resulting costs per treated person, and we looked at the program costs. And all of those are also being done for Scala. In this, we basically have the following scenarios. And we see how they work and what are the mechanisms. It is very simple and very clear. If you raise a price, if something is more expensive, people will buy less. This is even true for people who are having an alcohol use disorder. They're less flexible because of their problems, but that still will reduce. The enforcement of bans and restrictions will also help, but this is a more long-term measure. Physical availability is a very widely measure, and we have just been analyzing new data from 3 countries, especially from Lithuania, which did quite a lot of enforcement of restrictions, and seen that it still works even in high-income countries. Then the enforcement of drink driving laws have shown effects in almost every study. And finally, the provision of brief psychosocial interventions for people with hazardous and harmful use of alcohol have also been shown in many studies, and there have been more than 10 meta-analyses on those, and our results are based on one of those. This is the one where we based our results on, and this had similar results in various other meta-analyses. The last Cochrane meta-analysis was by Eileen Kainer. Basically, we modeled the other policies based on meta-analysis or based on large-scale studies, with especially some of those studies had to be in low and middle income countries. So how much would such an intervention cost? And you see that even though it is relatively cheap, especially in low and middle income countries, screening and brief interventions are costing the most of all of those 5 interventions. If you go into the effects, and again, we split it up between upper and high income and lower income, you also see that the healthy life year gains are the most, almost the most, for screening and brief interventions. And you can gain also quite a lot. So what you have is, even though screening and brief interventions is more costly than raising taxes, it is also quite effective. And it's way more effective than enforcement of drink driving laws or enforcement of restrictions of the physical availability or the ban. So what does that mean in terms of cost effectiveness? What is the average cost effectiveness ratio? Overall, this is best for increase of excise taxation, both in low and middle income countries and in upper income countries. Then would be the comprehensive ban on alcohol advertisement, and screening and brief interventions are still quite cost effective, but less effective than those three best buys. What does that mean now? Does that mean we should not do screening and brief interventions? No. The study was just reiterating that the three best buys are really the most cost-effective options, but other options in SAFER also should be used, especially since we know that the best buys are used very inconsistently. If we look into something like the price of alcoholic beverages, and we've just done a huge study over the last 20 years in Europe, it is incredible how low taxation is in most countries. Alcohol has become more and more affordable. And since, for whatever reasons, a lot of countries are not willing to impose the other best buys, screening and brief interventions is even more important. Another consideration is not to compare it against best buys, because it is highly unlikely that a lot of countries will increase their taxation rates by 100% or by 50%. 50 were modeled in the study. And for the payer who pays for those screening and brief interventions, they may still be cost beneficial, meaning that what comes out for, let's say, a Ministry of Health or a health providers organization is actually outweighing the costs which they have. And these cost benefit ratios or return on investment are currently being studied for Scala. If I had the results, I would be at the end of this presentation. And so I'm only telling you that part of the Scala project will be that we will be able to inform ministries of health and health service providers in all three countries about the return on investment. How much do they actually get in treatment saved for the dollars they invested in doing those brief interventions? And this is my closing remark for a little bit wider introduction. Thanks a lot for your attention.
Thank you very much, Jürgen. It was very clear. And we're going to go now to the three countries and their experiences. First with Colombia, with Augusto Perez and Juliana Mejia, who collaborated on that too. Augusto Perez is the principal investigator of the Scala project in Colombia. He is, I'm going to switch to Spanish, fundador y director de la Corporación Nuevo.
Founder and director of the Nuevo Rumbos organization. He's a doctor. He's got a doctorate from the Louvain University in Belgium. He's a visiting teacher in London, New Jersey, and he's a professor at the University of Los Andes. He has 25 years as a teacher and therapist. He's written 16 books and 180 articles in Spanish, English, French, Portuguese, and German. I believe he is the one making the presentation, but Juliana Mejia is the co-researcher for this project. She is the director for prevention of this new Rumbos Corporation. She's also a social worker at the University of Caldas, a master in anthropology from the University Los Andes, and she began her doctorate at the Faculty of Health, Medicine, and Life Sciences Health Promotion at the University of Maastricht in the Netherlands. Currently, she is responsible for design, adapting, and implementing community and preventive processes, both domestically and internationally. Augusto, you have the floor. Also a collaborator that for PAHO and for many, many years. Thank you. Could Juliana also participate in this presentation? Yes, of course she can. Yes. I will present the first two, then Juliana will present 4 more, and then I will return for the last 4 slides. Very well understood. Thank you. Our experience with Scala has been fascinating. Perhaps you could show your screen in presentation mode. Is this better? You need to click on presentation format.
En modo presentación.
Ya viene, pero se demora un poquito.
It takes a couple of seconds.
¿Ahora sí la ven bien?
Can you see it now? No, unfortunately not. We're only seeing half a screen now.
Y ahí.
Is this better?
No.
No.
Nos va a tocar, vamos a tener que verla como antes, en donde se ve el lado izquierdo, ¿no?
I'm afraid we're going to have to view it in the form I first shared with you.
Compartilha novamente.
Share screen again, please, Augusto.
Ya va a aparecer.
It's a bit slow.
Tendríamos que verla así.
Está bien.
I'm afraid we'll just have to make do with this format. As I was saying then, for us, working with Scala has truly been a very interesting experience. As you can see on this graph, data collection varied from month to month, and there's a strong increase through November 2019, then it drops, which is to be expected in December. In Colombia in December, work drops significantly, especially starting on 10 December and going on through 10 January. Then in March, there's another drop. That's the beginning of the pandemic. So from March through August, we didn't really gather data. In August, we started doing so again. And the number of data collections from screening decreased gradually through January. In February, we had some social problems in the country, and they extended through March, and that actually was the worst month in recent Colombian history, with mass demonstrations in all the cities, making it very difficult to collect data, especially because the sites where the collections took place was one of the most problematic from a social standpoint. So in this presentation, we want to talk in particular about the challenges we encountered and the achievements, how we were able to tackle them.
Bueno, al poner estos datos como con la
By
lupa,
sharing the data, we see that most of these measurements was under risk, 96%, of which 8.5% was brief counseling, using a score from the audit, a complete audit. There was phase 1 prior to pandemic, then phase 2 post-pandemia, and then after the pandemic. That was the short package. And the PHQ-2 was applied, PHQ being for depression. But 10% already had this measurement due to depression. And the other scores were too low, whether it be suicide or remission. So it's less than 1%, and also depression. The interpreter regrets, but it's very difficult to understand this speaker because there's a lot of echo. Most of the cases were women, 79%, men were 21%, an average age of 45 years. Next slide, please. We had to confront many challenges, as Augusto pointed out. The first was to find the work sites. At first, when we began to implement the project, people would say, yes, yes, I want to be involved, but actually it was quite difficult to find the right place to perform the study. But we have different links, and in one community, we found the ideal place to conduct our work, and it actually was very effective. We needed to awaken interest of health professionals who were going to be involved in the study. Health representatives, doctors, nurses, dentists even. Very few psychologists and social workers, because the care centers do not really have a specialized center with lots of professionals, so it was difficult to involve them.
El resultado es que se encontró con un alto tamizaje, como ya lo mencionó Augusto, casi con...
So we were able to conduct a high number of screenings, about 13,000. Another challenge was to create an effective community advisory council. As Mr. Anderson pointed out, it's important to have this community support, and it was key for the success of Scala in Colombia. These committees work very well. There are people involved from the Ministry of Health and from the local government, the community, and the hospital. And they provided strong support for any situation that would arise during the implementation process. They provided a lot of encouragement to scale up the process in Colombia. The next challenge was to convey to the national government how important it was to scale up the project. We had a talk with the health vice minister and government advisors in order to present the project to them. And to our great surprise, they supported it from the outset. And actually, recently, we had a meeting very similar to this one. We did it with Mexico, and publicly the representative of the health ministry stated that the ministry was interested in having Scala reach out to the largest possible number of places in Colombia. And the government of Cundinamarca, which is one of the largest departments or most populated, and which includes Bogota, the government of Cundinamarca asked us to provide training to the health staff. healthcare professionals. Another big problem was due to a change of administration, and that had a major impact because a new mayor was elected and the director of the hospital changed, and that changed a lot of the staff. And the person that we had been working with very efficiently was changed. And that can be seen very clearly in the graphs that I showed you. There was a significant drop after that change, a drop in the number of interventions. However, we were able to pick up the pace afterwards, and even at the worst point in time, on the one hand, due to the pandemic, and on the other hand, the social mass demonstrations, in that month, and I believe that was March or perhaps April, we had achieved over 600 screenings. Due to the pandemic, we also encountered one community that we used as control. And the members in that hospital and health center said that they didn't want to continue with the project. We even offered them conditions that they could consider as being favorable, but they said no, they preferred not to be involved. But nonetheless, through our links to the government of Cundinamarca, we were successful in having 2 other municipalities agree to join the project, and we are currently working with them. Lastly, throughout the 18 months, we needed to keep the primary healthcare centers, they needed to continue being interested. And this is quite difficult because, as one sees in so many countries, I would have thought that in all countries of the world right now, but the doctors are overburdened, and what we were asking them was adding yet another task on top of everything else they had to do. So what we decided to do was provide some incentives. Basically, these incentives were some quarterly awards to all the primary healthcare centers that could achieve the largest number of screenings. And at the end, to each one of the 9 centers, and one is in Suacha, we gave them a large format television, and that was actually part of the communication campaign that was carried out for people to become totally familiarized with the Scala project. We believe we were successful, and Juliana is actually working on that right now, and she is responsible for the process to assess communication at these health centers. We believe it has worked quite well. So these were some of the principal challenges we encountered during project implementation, as well as how we were able to address them. Thank you very much.
That was very interesting presentation. And I just realized that we have not discussed briefly what it was the methodology of the project Scala. So before we move to the other 2 presentations, I'm going to give the floor to Peter Anderson to provide a few words on how it was planned. Thank you.
Thank you, Master, and apologies that we did not make this well clear. So Scala essentially is a implementation project. It's a research project about the impact of different implementation methods in encouraging primary healthcare providers to measure the alcohol consumption of a greater number of their patients, and to give advice to those found to be heavy drinkers. Essentially, we have 3 cities involved in the project. We have Lima in Peru, we have Bogota in Colombia, and Mexico City in Mexico. In each of these cities, we identified local communities, and within the local communities, recruited the primary healthcare centers to be involved in the project. Essentially, the project was comparing the impact of training and the impact of providing community support and local communication campaigns compared with normal practice. So this means essentially we had three arms. We had an arm where there was normal practice, where we provided no support, no training, no interventions to the primary healthcare providers. Then we had a group of centers in which the providers received training, and then a third group of centers in which the providers received training, and then local community support and local communication campaigns to advocate for the work that was being done. In each of the centers, all of the providers were invited to ask or to measure the alcohol consumption of every adult patient who consulted them for whatever reason. And we used the Audit C instrument for this. The Audit C is an instrument that has three simple questions that asks about alcohol consumption. And based on the answers to those questions, there is a score. Normally with the Audit C, you use a score of 5 or more to indicate whether or not you should give advice to someone to reduce their alcohol consumption. In Scala, we did it a little bit differently because we were more invited to focus more on the heavier or more problematic drinkers. So actually we used the score of 8 as the cutoff to indicate when advice and or consideration for referral to treatment should be given. But that was something special for Scala. Normally you would use a score of 5 with this Audit C instrument, but we used 8. And then in addition, because we were also asked to do this, we also considered whether or not people who were consulting might have had depression or depressive symptoms that could be related to their drinking. So anyone in the project who scored high on the Audit C was also assessed or screened for depression using this PHQ 2-item instrument. So basically we were investigating in the project, did training on its own lead to a greater number of patients being screened and advised? And then did training plus the provision of community support lead to even more patients than just training alone being screened and advised? To test this, we set out to do this over an 18-month measurement period, but unfortunately, due to COVID-19, we had to change that. So we had an initial 6-month period, and then we had a pause while we readjusted the materials, and then we've had a second 6-month period that's now drawing to a close. So that's in a quick summary, the method of what we've been doing in Scala. Thank you, Marista.
Thank you very much. That's useful and gives a background for everyone. And now we're going to continue with the presentation from Peru. It's going to be shared by Inés Bustamante and Marina Piazza. And first, Inés Bustamante is co-investigator in the Scala project in Peru from the Caetano Heredia Peruvian University. She's a psychologist from the Catholic University and a diplomada em Salud del Adolescente com mención en Salud Reproductiva, Universidad Peruana Caetano Heredia. Magister em Saúde Pública, Universidade Peruana Caetano Heredia, e doutorado e magistério em Ciências de Saúde, Faculdade de Saúde Pública da Universidade de Johns Hopkins. Después va a seguir con Mariana Piazza, la investigadora principal de este estudio. She is a full professor and head of the Alcohol, Drug Use and Mental Health Research Unit in the School of Public Health and Administration of Universidade Peruana Caetano Heredia. She holds a master program in public health and a Doctor of Science degree in drug dependence epidemiology at Johns Hopkins. She has led in Peru international studies, including the Gender, Alcohol, and Culture Study, Genesis, the World Mental Health Study, and the International Alcohol Control Study. She has led implementation research, such as the PAHO WHO Improving Program Implementation through Embedded Research IPEER initiative, and has participated in the WHO ICD-11 Working Group on Disorders Due to Substance Use and Behavior Addictions. She was awarded with the Elsevier 2018 award in recognition of her production of scientific articles. So Inés first, and then Marina.
Y buenas tardes, buenas noches.
Good afternoon or good evening, as the case may be. We will be presenting the adaptation of Scala to this very difficult context in which we have been working due to COVID.
Se ha notado la fragilidad de
We have seen the fragility of our health system under the pandemic, especially at the primary healthcare level.
Entonces, el 15 de marzo
On March 15, 2020, the emergency state was declared nationally in Peru. To date, we have 191,286 deaths in a population of just over 32 million.
La vacunación del personal
And healthcare vaccination began in February of this year,
los médicos
showing that doctors who died in Peru accounted for
los terceros en América Latina en cuanto
the
a número,
third
en cuanto a
highest number in Latin America. In May 2020, there was also strengthening of actions having to do with health by implementing telemedicine. So we see that this is a context in which there has been mortality and disease amongst healthcare providers, and obviously a lot of stress, fear of contagion, and overwork. So the healthcare professionals were always split between meeting their vocation and taking care of their families, two competing emotions. So we conducted a number of workshops for healthcare professionals, give them emotional support so that they could understand what they were living through, and at the same time allowing them to identify resources that would provide them with support. And this was done individually and in group format. So we began the emergency state on 15 March 2020, as I said earlier. There was a very strict lockdown at first, and primary healthcare centers were basically closed down. Today, they're working at 50% of their capacity, and we can see that many professionals, especially those who, due to age or risk of contagion, because of that, we had only the 50%. Users are also fearful of contagion. Some policy regulations were implemented encouraging, in particular, telemedicine, especially when it came to pregnant women, as well as people suffering from chronic disease. So that's the context when we implemented Telescala in order to restore communication between users and professionals, as well as between health professionals participating in Scala and the researchers.
Los profesionales y usuarios cuentan con celulares.
Professionals and users have cell phones. There's a very high percent of mobile telephones in Peru. And health professionals also have internet available at their homes, but there is no internet for them when they go to the healthcare center. So in this context, during the COVID pandemic and given the policies that were in place at the time, telework became available for the screening as well as brief counseling services having to do with alcohol use through telephone communication with users. Healthcare professionals involved in the project and actively participating in the screening can also do it in face-to-face interventions. So whether it was by phone or in presence, the screening can take place. The form can be filled out either online on the internet or by mobile phone. The data is uploaded to a database that allows us to
Muy bien.
gather the data.
En síntesis,
In summary,
tal como, se ha
this
ido comentando,
intervention, as we have been hearing, it starts by
el problema del alcohol de la oscuridad, digamos,
bringing to light the problem of alcohol use. This is something that's hidden within the community, hidden in the households due to the stigma. And this problem is not identified in a timely manner, and it is not referred to professionals, and there is no intervention. So thanks to the screening, there can be some immediate intervention so that the level of severity of alcohol use in the population doesn't become more acute,
en niveles de riesgo
and working effectively on risk factors.
que permite
So this
incorporar
intervention makes it possible to
de las diferentes
take advantage of the strengths from different areas of ambit for primary care and the contact they have with the population. So that provides training so that physicians, psychologists, obstetricians, nurses, psychologists, whenever they see a patient for any other reason, because generally they don't come to see a professional to talk about their alcohol use, but questions are put to them to assess their risk level, and they are classified in a low, medium, or high risk of alcohol use with the 3 Audit C questions. Likewise, with all patients, to see if there are any symptoms of depression and suicide with the PHQ-2 questionnaire. And then depending on the risk level, there are 3 options available. Either they are congratulated and they are told to continue with the same behaviors if they are at a low risk level. If the risk level is medium, then they receive brief counseling and brochures, and at higher risk, then they are referred to a specialized service that may be in the primary healthcare center or perhaps at a community mental health center.
¿Qué hacemos?
Now, as Ines was saying, what are we doing now that we have a digital questionnaire? It can be handled from the cell phone even, and that facilitates communication in terms of adding up the score. That's done automatically. And then the intervention format is suggested immediately. And at the end of the process, the health professional sends in that form. It goes to a database, or it can be printed, or it can be stored as a PDF in the patient's clinical history. Also, there are different brochures, different pamphlets that are sent to the patient to provide support. So what you can see here is a flow diagram where you can see all of the adult patients that can be screened depending on the abilities of the professionals. And there are 4 different options, different combinations of Audit C and PHQs, and that determines if the person merely receives information on alcohol for that person to engage in healthy behaviors. But if there's a risk, then an intervention is provided with a pamphlet that is more in keeping with that risk level. But if in addition to that, the patient has depressive symptomatology, that is supported by giving information on depression. And also we assess the suicide risk. If there is a suicide risk present, then the intervention is much greater. That is why we have provided training. We wanted to move Scala to Telescala, and this has to do with how these pamphlets, how these materials were managed, how they were sent to the patient, and different aspects having to do with communication over the phone. Since we did Telescala halfway through the project, we had a 1-hour training session with all professionals, and the idea was to provide digital screening. And then we had some new professionals who wanted to join, and there we trained them about brief interventions in terms of how to manage communication. Now, here you're seeing some guidelines that we developed. Here we tell the provider what they have to do to provide telecounseling on alcohol and depression. You need a cell phone, you need the cell phone number of the user, you have to have the link to informational materials. So first of all, the provider calls the user over his cell phone. And if the person accepts, the call is put on hold and it's minimized, then they use a link to go to the questionnaire. This is the way it looks. And there they go through the exercise and at the end send in that screening. But you can see the different screens that suggest what the healthcare professional needs to do. And at the end of the process, that form, that screening form is submitted. And by WhatsApp, the professional sends out these informational materials. There are more things that go to the riskiest population. So thank you.
Muchas gracias, Marina.
Thank you very much, Marina. Thank you, and Inés.
Mexico, with the presentation of Guillermina Natera. She's the principal investigator for Mexico, licenciada en psicología por la UNAM, maestra en psicología social por
She has a master's in social psychology from UIA. She has a master's in science, specializing in education from Sinvestav. She has a doctorate in anthropology from the National Anthropology and History School. She has specialized as research in addiction, mental health, family, and intimate violence. She has represented the National Psychiatric Institute in several international meetings. She's an expert in this issue. She has received rewards from the World Health Organization and the National Ramon de la Fuente Psychiatry Institute. She is a researcher in medical science. She has an F grade, and she is the coordinator of National Institute in Health and Highly Specialized Hospitals. She's a national level 3 researcher of the National Research System. She also teaches in the National Medicine School, and she has carried out studies in the United Kingdom and in Finland with Kri Munam. She has published more than 200 scientific articles in national and international journals and has written 3 books. She has given more than 350 national and international conferences. She is the director of 28, the Collaborating Center for WHO in Research and Training in Mental Health and Substance Abuse. She is a researcher in the Epidemiological Research Department in the Ramon de la Fuente Psychiatric Institute. Her co-researcher in Mexico is Perla Medina. Ms. Medina has a degree in psychology and a doctorate in social anthropology. She has worked in indigenous and rural communities since 2005 with different research projects, emphasizing the family perspective and looking at violence against women, working at excessive alcohol use, young people, and drug trafficking. At the present time, she is part of Mexico's Scala project. So Guillermina, I turn the floor over to you. And I should say that it was Guillermina that promoted this seminar. And she insisted that we have this seminar, and it's a pleasure to be with you today. Thank you.
Ha habido un problema, no sé si me están escuchando.
I thought I had a problem, but I hope you can hear me. Yes, we can hear you fine, but we cannot see your screen.
Ahora sí.
Here we go. Great.
Bueno, no
Okay.
vamos a hablar mucho porque es necesario el alcohol. Peter ya lo ha hecho con bastante detalle.
I don't have to tell you why we're interested in studying alcohol. You know already, thanks to Peter. But this is a problem in Mexico. And here on this chart, you can see how alcohol consumption has gone up. This is a survey that goes from 2011 to 2016. And that is why this project is so important to me. I think it's very relevant, especially in terms of primary health care. As Peter said, the Scala project, here you can see the city of Mexico. It is a multicultural city in many ways. And early on, back in 2019, 2018, when we did our training, oh dear, I don't know how to solve this. I lost my slides.
¿Está compartiendo todavía?
Todavía estoy compartiendo la pantalla. Es que aquí me apareció en mi pantalla.
It says I am sharing the screen, but here on my screen, it says I'm not sharing.
Tal vez si ustedes tienen la presentación.
If you had my presentation, could you please show it?
Bueno, ahí está.
Great. Yes, here we go.
Ponga la visión más larga ahí. Sí.
Sin embargo,
If you
no
could enlarge it.
reacciona. ¿O sí reacciona? Okay.
Ahí.
Okay, here we go.
Perfecto.
Tenemos que teníamos 163 profesionales.
We had 163 professionals and 5 different mayor's offices. And the 3 phases are here. Implementation, as we know,
En esta planeación y básicamente
was affected by COVID,
en este periodo de marzo-octubre del 2020.
and there was interruption between March to July of 2020. So this is the methodology. That's something that was already explained by Peter too. And here on the right, you can see the information, the written information that is given to the patient, depending on the score of both Audit C or PHQ-2. Now, what are the activities of the project? We do training and ongoing counseling of our healthcare providers. We have learned how important daily contact is and adapting clinical materials and educational materials according to the needs of the population and the counseling that needs to be given. These activities were carried out through community action. There was a community advisory council that participated. These were people that were experts in addiction, and that led us to looking at how we could improve on our information materials, as well as the different tools. Also, the Project Champion is part of the project. That is the linkage with the authorities in the Secretariat of Health and the health care centers. And that is because we have liaisons in each center, and that helped make the program successful. We have adoption mechanisms. This is provided by the liaisons, and then a support system. This is done through the patients that go to the centers. They helped us assess the instruments, the tools used by the program. They told us what made the best sense to them and what they found most helpful. So once again, and I don't know why this is happening,
No, solo ponga la presentación ahí, sí.
Ok.
that's
Es
good.
que aparece en mi pantalla como si se fuera,
My,
¿no? Pero pues,
my
por lo-
screen looks like I'm about to lose it, but apparently not.
Sí.
Can you make it bigger?
Ahí.
Okay.
Bueno, ha habido muchas interrupciones en este
I'm
sentido.
sorry for all the interruptions, but here you can see the posters that were part of the communication campaign during the COVID time. And also we produced some videos. Here you can see how we were affected by the COVID in terms of the care that we gave at our healthcare centers. You can see this big drop in screening and in consultations, especially between April and July. You can see that there was a drop in both the visits as well as the screening. But then after that, there is an improvement in terms of the people working in healthcare centers, and also screening is up. That applies to Peru and Colombia too. Most of the population is women. We have more women patients, but I think that in Mexico, perhaps it's the other way around. There are more men than women. An interesting thing is that the second phase of implementation, you can see here that there were more people of higher schooling, whereas in phase one, we had people with a poor educational background. Now, you have to realize that this part of the healthcare system in Mexico is for people that have no fixed jobs. So these are people that have very little support, and they require our support more than anyone else.
We have focused data on alcohol use. We can see that in the second implementation period, when there was an increase in screenings and consultations, we were able to recover risky users. Due to the pandemic, there was great mobility amongst patients. Many centers were focusing simply on detecting COVID cases. In the second period, then from March to October, screening was implemented again, and we were able to recover some of the centers. Why do we believe that Scala works? And what are the lessons learned? The intervention was adapted to the context of primary healthcare centers based on the indicators I described. There was a reduction in the gap between knowing and doing. We integrated voices of involved stakeholders and periodically make known the intervention and results obtained. At the first, there was also a number of beliefs that were expressed even before the training was provided. They told us about certain beliefs, and both healthcare providers were able to find ways to change these different beliefs. Many patients don't want to talk about their use, and now patients are open to talk about alcohol use. This is an expression of interest from the physicians towards the patients. Health professionals were able to successfully integrate this in their daily activities, despite having thought that it would take up a lot of their time. They thought that a brief intervention could have a positive outcome. This is something that we heard very frequently from healthcare providers in the period. And once again, I have lost my screen. I don't know if it's something I'm doing or if I'm having a problem with my connection.
Debo decir que se congela la imagen en mi computadora y entonces...
The image freezes on my computer, unfortunately, and then it boots me out. So involve the healthcare personnel in the implementation process favors the implementation of the program, both during this period as well and in the future when we want to scale it up to other centers after finalizing the research. Why does Scala work? Well, in the statistical model, we can see that the information makes it possible to use available resources involving the personnel in the intervention. One of the important aspects that made them supporters is that they believe that the intervention was useful and that they are part of an integral policy for a better future. The healthcare policy right now in Mexico consists in strengthening the primary care level in mental health and addictions. Scala has identified different opportunities at the first level of care. Research done by Dr. Berenson in 2018 found all of these obstacles, both to assess mental health and addictions in Mexico City. We found that Scala is able to provide reliable brief instruments of 3 to 5 minutes in order to overcome resistance by healthcare providers. Another element identified by Dr. Berenson is that there are problems in the referral and counter-referral system, but what we have offered them favors communication and referrals between the different levels of care. Collaborative work, according to the study, is complex between the primary level personnel and mental health specialists. To have a link between health providers has made it possible for them to obtain vast and complete information throughout the period. Yet another opportunity is that the Scala project suggests considering the detection and brief counseling as part of providers' productivity. And for them, this is extremely important. If they have additional responsibilities, they need to receive compensation. And this is something we were able to develop with the authorities of the Mexico City Health Department. And they did indeed decide that this would be part of their productivity. Counseling strengthens community links and action, so the health provider is constantly aware of this. And lastly, the health provider not only provides counseling, but also shares material with the patients that they can take to their home. This happened in many cases where women, although they were not the users, they were very grateful to receive these brochures because their partner, their husband, or their son could find these brochures very useful. So through all these lessons learned, the project was able to be implemented more smoothly in Mexico, and actually it was successful. And we'd like to thank all the members from the Mexico City Health Secretariat and all the medical personnel who enthusiastically participated. And as Augusto pointed out, even the younger people became kind of competitive between the different health centers that were in touch with one another, because we did have meetings to continuously share information as to their progress. And they sort of became internally competitive to ensure that Scala was adopted and implemented as fast as possible. So I'm very grateful to the Scala team who have been collaborating from the outset in this project. And thank you also, Maristela, and all the listeners. Hopefully we have been able to convey to you a clear message of why Scala can truly help Latin American countries where alcohol use is characterized as being the lead in addictions. Thank you.
Thank you very much, Guillermina. And we're gonna finalize with discussion moderated with Peter Anderson on the outlook beyond this implementation period. And with some time, if maybe for one or two questions before we close. Thank you.
Thank you. I was, let me just put up, Guillermina, can you stop sharing the screen, please? Because I need to just put up some slides. Thank you. Okay, perspectives.
Yeah.
I'm just going to finish very briefly with some perspectives from Scala, and then we will continue with questions and comments. Just in the slides at the bottom right is the website of the Scala project. So all of the material, everything that one needs to know about Scala, including many of the communication materials, is on this website in both English language and Spanish language. So if anybody wants to find more, please browse through and look at the website. 4 key perspectives. And what has come through all of this is that primary healthcare providers can implement brief intervention programs to reduce alcohol use. We demonstrated in Scala that trained providers measured the alcohol consumption of nearly 10 times as many patients as untrained providers. We've also shown that providers who received community support, including communication campaigns, measured the alcohol consumption of about twice as many patients as providers who received no community support. It's vital, and that's the key message that has come through all of these presentations, implementation and scale up is an adaptive process. It's a process that learns and adapts as one goes forward. And COVID-19 has taught us resilience and flexibility, adapting programs to external stressors. And as we heard in Peru, asking and advising has shifted from face-to-face contact to telemedicine. And what is amazing is that even with severe external stresses, work can continue. We have heard during Scala there have been major external stresses, not just COVID-19, but also political turmoil. Despite these, and this is great credit to the providers who have been involved, it has been possible to continue measuring alcohol consumption and giving advice to patients to drink less. I think this illustrates that the providers themselves really understand the importance of this work, and they themselves see it as important to do. And finally, monitoring and evaluation are key. We need to monitor how well we're doing. The main indicator should be coverage. What proportion of the adult patients that we care for has had their alcohol consumption measured? So thank you. So with that, let's continue now with questions, comments, and any input from others.
Thank you very much. If anyone has questions, you can put in the Q&A, or it may be possible to raise your hands or in the chat. We'll be happy to answer. I would like to ask a question, actually, to start to Guillermina Natera, because brief interventions for a long time have been used and studied in Mexico. What do you think was different this time to make it so effective?
Bueno, yo creo que en esta ocasión fue toda esta...
I think in this case, it was the preparation involving the healthcare providers. We have absolutely no doubt that to be close to them from the outset, I must admit there was a lot of resistance at first, saying, oh, you're going to be giving us more work. But when we went and explained to them, this is the Scala project, this is how we're going to work, we're going to train you, we're going to have communication with you, we will be providing you with material and support. That was very important because the healthcare centers don't have the economic means to acquire material. So we provided it with them, we gave them evidence, we taught them how to score, we told them how to be pleasant to the patients, we even had interpersonal training. They could call us at any time, whenever they wanted to. This was highly productive and very efficient. The fact that periodically we gave them outcomes, because every 2 months we told them what the results were for their center as to the screenings, and they could describe to us the problems they were facing. And I think it was thanks to this and the contacts between the providers that we gradually were able to convince them and bring them on board. When young people saw the results, they would then see, hey, why is my center doing less screenings than the other one? So that encouraged them to be competitive. They received support also. We also offered courses available at the Institute, and these were offered for free whenever they wanted to, they could register. So all of this encourage them and allow them to see, oh, you're not just giving us instruments, use them however best you can, and then we'll come in a year or 6 months later to pick up all the data. No, they all asked us how many screenings they had to do. We set no target for them, actually. You can do it in whatever way you can with all your patients that go to you see you for the first time. Use the instrument with them. I think all this communication is what made it so good for the Scala project to be implemented.
Can be for any of the sites. ¿Cómo podría extenderse la capacitación a todos los profesionales de salud?
How can we train all healthcare professionals? How could we accelerate public policies in this way? I don't know if anyone else wants to answer. Marina, Augusto? Well, I think that a very helpful tool to be able to extend this intervention would be to have training that is on an online platform, because that would be very helpful. Then another aspect is to have a structure of supervisors and trainers so as to work with health networks. In the case of Peru, that would be the community mental health centers. So involving the professionals from those centers so that they could train primary health care staff so that they could provide support. I think that that could be a strategy, at least in the case of Peru. Thank you. And Peter?
Yeah, thank you. I mean, I think that, the more that we can do to accelerate the process, the better. But I think we should also realize that, this is a long journey. It just does take time to persuade everyone that this is important, to implement, to develop, to expand it. And so we have to be a little bit patient that we can't suddenly overnight get everyone doing this. It just takes time to get that process going. So even in the, some of the countries that have been at this longest, you're talking about, 10, 20 years before you move from a very low level of work to something that is really, really kind of meaningful. So we need to be a bit patient and just keep at it steadily, expanding.
Sorry, another question is, ¿qué prioridades en salud global?
What are the priorities in global or international health for Scala in terms of health problems.
Totally clear, but
Not totally clear.
Scala to global priorities.
I mean, I think that if I can answer that, I mean, I'm not quite sure what's behind the question, but I mean, I think that the principles of what we've done in Scala is for alcohol, but these same principles apply to other behavioral risk factors. They apply to helping people stop smoking. They apply to helping people to be more physically active. They apply to help people who are living with overweight or with obesity, to help them manage that. You know, they apply to people changing their diet. So I think there's what we've demonstrated is that you can help providers do more with one behavioral risk factor, in this case alcohol, but there's no reason why we couldn't expand that through to these other risk factors as well, and even do it in some kind of coordinated approach.
As you are coordinating already with the European region, right? Yes. Jürgen?
Well, I was mainly going to say the same thing as Peter said. Scala is a project which had been funded for alcohol, but we can and we should use it as a means for other behavioral risk factors on what can be done in a number of not only substance use, but other mental disorders and physical disorders.
And I have a question for you, Jürgen. Even with the limitations of the COVID imposed to the implementation of the Scala, can we get data eventually on the cost benefits? And
yes.
Yes.
The simple answer is yes. We are about 2/3 into analyzing those data. We have a program, we have all the costs done. What is currently being done is doing the link between the reductions which you have seen in the different countries in drinking and their impact, their expected impact on hospitalizations. And that can be done even without COVID, because we do have data for the relative risk or that link independently for those countries. And the cost data are very specific, and we know how much a hospital bed would cost in each of those countries. So I'd say another 2-3 months and you'll have the data.
Okay, so another webinar to look up to. And the final question, because we gotta close now, is ¿qué opciones se pueden implementar cuando los centros de salud no
What are the
tienen?
options if healthcare centers don't have internet? Is this the only way to apply the project? Well, what we are using is we're using the internet connection, the data capacity that professionals have on their personal cell phones, because that's a reality. Often these healthcare centers don't have an internet connection. So the project is providing as an incentive this capacity to have greater data on their cell phones. So until we have suitable internet connections, the professionals are using their own individual cell phones. That is the option.
Maristela, you're on mute.
Tiene apagado su micrófono, Maristela. Tenemos
Questions that I can send to you to answer, but I want to thank you again for this wonderful opportunity. Thank you, Guilhermina, for pushing that to happen, and all of you for being on time and participating, and all the participants as well. Thank you.
Thank you.
The webinar has been recorded, and we're gonna soon send also the recordings to everyone. Please feel free to disseminate.
Muchas gracias.
Further. Bye-bye.
Bye.
Ok,
Well,
gracias.